Good morning, everyone. First of all, I would like to thank the Southeastern Surgical Congress for the privilege of the podium and for allowing us to present our research. I have no disclosures. The focus of trauma systems is early identification of serious injuries and the provision of timely and adequate trauma care. This is often achieved by means of an effective triage, which helps minimize preventable deaths in trauma patients by provision of early and timely care to these critically injured patients. And this is a hallmark of a mature trauma system. There are several pre-hospital scoring systems that have been used to allow triage of these patients. These scoring systems are based on physiologic parameters and help identify patients who would benefit from triage to a trauma center. This is one example, which is the revised trauma score, very commonly used in the pre-hospital setting, based on respiratory rate, systolic blood pressure, and GCS. As you can see, an increasing score is associated with higher survival. However, the use of RTS or other scoring systems such as the TRIS or MGAP score is mostly limited to the pre-hospital settings and only helps triage patients who should get to a trauma center. However, once these patients get to a trauma center, they are initially evaluated by the trauma teams in the ED. Their final plan for disposition to the ICU or elsewhere requires the identification of their definitive injuries and extensive workup, some of which can take several hours. This inevitably lengthens their ED length of stay and is very often also seen in patients who are critically injured and need ongoing care in the ICU. When we looked at the literature, currently there are no tools that can help clinicians make decisions early prior to their definitive injury identification. So our aim was to develop a simple and rapid assessment tool that can be applied with ease during the initial evaluation of trauma patients when their final injuries have not been identified and can reliably predict mortality as well as the need for ICU care in adult trauma patients. We hypothesize that a simple scoring tool based on age, GCS, and shock index, which is a ratio of heart rate and systolic blood pressure, can reliably predict the mortality and the need for ICU in these trauma patients. To do this, we used the National Trauma Data Bank. We included all patients 18 or greater years of age. We excluded patients who were transferred from other hospitals or patients with no signs of life. Our outcome measures were mortality and the need for ICU admission. We created our scoring system in 4 simple steps. In the first step, we identified all the factors that, in our opinion, directly impacted the mortality or determined the need for ICU admission prior to identification of their injuries. These were 3 important factors: the hemodynamics, age, and neurological status. In the second step, we identified one representative vital sign or parameter for each of these factors. For hemodynamics, we chose shock index greater than 1 for ease of use. We chose age of 55 as a cutoff based on previous literature, such as in the TRIS score, and GCS, which is a representative of the neurological status. We then included these factors in our multivariate regression analysis and calculated the odds ratio for all of these factors. We then rounded off their odds ratio to the nearest whole number and assigned appropriate weights. This gave us our score system, which is basically based on shock index, age, and GCS, hence called the SAG score. We then calculated the SAG score of our whole population and divided them into 3 cutoffs, dividing them into high, intermediate, and low-risk population. Coming to our results, we had 281,522 patients. Mean age was 47.3. 35% of our population had age of greater than 55. We had 5.9% population with a shock index of greater than 1. And the median interquartile range for our GCS was 15. We had 28.7% patients admitted to the ICU and 5.6% mortality rate in our population. As mentioned, we performed a multivariate regression analysis taking these 3 factors into account. The odds ratio for mortality for shock index was about 3. For age, it was about 4, and GCS had an incremental association with lower mortality. In essence, to calculate a SAG score for any patient, any care provider would need 3 basic steps. Number 1, you look at the shock index of the patient. If the patient has a heart rate greater than their systolic blood pressure, in essence, they have a shock index greater than 1, which will give them 0 score. If they don't have a shock index greater than 1, it will give them 3 scores. Similarly, age. If you have an age less than 55, you would get 4 points. On the contrary, it will give you 0 points if you had age 55 or higher. For GCS, for the ease of use, we elected to give a value of GCS contributing towards the SAG score. So everybody would get 3 to 15 points based on their GCS. So any patient would get a total score of anywhere from 3 to 22. In our population, the median IQR for the SAG score was 21, ranging from 18 to 22. We divided our SAG score into 3 cutoffs. The high risk were patients who had a SAG score of 8 or less. 9 to 18 was considered the intermediate score, and greater than 18 was low risk score. As you can see, patients in the high risk had 20% mortality, and nearly 50% of these patients were admitted to the ICU. In the intermediate group, the mortality rate was 4%, and the rate of ICU admission was about 35%. In the low risk group, about 22% of patients were still admitted to the ICU, however, the mortality rate was less than 1%. We looked at the secondary outcomes in these 3 groups. As expected, all of these outcomes were significantly worse in the high-risk group, which included the hospital length of stay, the ICU days, the total number of days on the ventilator, and overall hospital complications. In order to calculate the accuracy of our score for mortality, we performed a receiver operating curve. We had an area under the curve of 0.873 for mortality. For our ICU admission, the AURC for our score was 0.644. We also compared our score to a previously established RTS score, even though this is used in the pre-hospital settings. However, just for the sake of measuring the accuracy, we wanted to compare it to it, and AURC for RTS was 0.824, which was lower than our scoring system. Since our scoring system heavily relies on GCS, we wanted to make sure that our SAG score was not, in effect, just representative of GCS. So we compared it to an isolated GCS as well. And you can see the GCS AURC is significantly lower than our scoring system. In conclusion, SAG score is a simple clinical tool derived from variables which can be assessed with ease during the initial evaluation of trauma patients and can be applied in the field or in the trauma bay. It provides a rapid assessment and can reliably predict mortality and the need for ICU admission in trauma patients. This simple tool may allow for early resource mobilization, possibly even prior to the arrival of the patient to the ED. Our limitations: this is a large retrospective database study. Our study is only in its first stage, so we at this time have a development cohort. We still require a validation cohort to establish the performance of our score in a real trauma environment. We did not take into account the mechanism of injury, and it is unclear how our scoring system will work differently for blunt or penetrating mechanisms of injury. With this, I would like to thank you all for a very patient listening.